Let's turn our attention to relapsed refractory multiple myeloma. And, let's assume our patient has had triplet therapy, transplant, and a maintenance therapy. Raphael, what are you looking at time of, what makes you decide to treat? Are you waiting for symptoms? Are you using biochemical relapse? Is it MRD changing from positive to negative? All of the above?
So that's an excellent question, and more so as we get better tools to measure the possibility of relapse. So I went to the place where everyone goes, Twitter. So I asked a question to my myeloma experts, friends, to say, when would you treat biochemical relapse alone, or does it have to be progressive relapse, or do you even have to have symptoms like evolving anemia? And the majority of the answers were in the middle. I think we all see patients who have a small level of biochemical progression, but we might observe for some time. I don't think any one of us wants to wait for a fracture or a severe problem. So it really is the dynamics of that relapse what I think is dictating how most people are thinking about the need for pulling the trigger for the next line of therapy.
I must say I've found myself jumping very fast onto even a small biochemical relapse and even a change in MRD from minimal to significant. I just feel we have so many good drugs now that are perfectly able to get things back in control before they get out of control. I'm very much more inclined to treat early rather than wait.
I think that in some ways that's actually good for patients, because if they had been in remission for quite some time and they begin to relapse, it can be very upsetting to them. So, and I think it can be very reassuring if the doctor comes to them right away and says, okay, you're beginning to relapse a little bit, but we have something that's going to get you right back on track.
On the other hand, the counter argument would be many of these people can go months, if not years, without any treatment and have good quality of life and be working in the workforce and not have to be in therapy. So that's the
right. But I mean, some people just can't take that stress.
Yeah.
Right? So
yeah, I would say that's more common than so some people will say, I'd rather, I've got a wedding coming up, or I'm just back at work. Don't make me have to stop work again, and they'll want to try and delay restarting, but I think your first scenario is more likely. What's your experience, Andre?
Well, I've applied very straightforward and simple rule until recently. Is this relapse meeting criteria to retreatment on clinical trial? Is this patient eligible for clinical trial by way of measurable disease and determination that by MWG criteria patient progressed? This was my kind of a usual measure for picking up time for a treatment. But right now I'm struggling actually with this. The more I test patients who are in remission and with emergence of group of patients who are by any criteria and stringent complete response, MRD negative by flow, 10 to minus 5, but then they are emerging with MRD positivity by next gene sequencing. So I know that they have residual disease. Should I treat it or not? How I measure whether I am really making good on treatment. So I would maybe bring with this comment, in my opinion, emergence of need to address this particular segment of patients in a clinical trial context. Because as you said, it is a huge commitment for the patient to go back on treatment, intensive treatment, rather than stay on Revlimid. Do we know that this is the right decision? So we should be testing it.
What is your treatment at first relapse?
For most patients relapsing on lenalidomide Revlimid maintenance, we have currently our clinical trial is KPD plus daratumumab, which is carfilzomib, lenalidomide, dexamethasone, and daratumumab quadruplet.
Lenalidomide or pomalidomide?
Sorry, pomalidomide, misspoken. I think outside of clinical trial for a long time, KPD, carfilzomib, pomalidomide, dexamethasone were my first choice. In recent years, with emergence of data on dara-pomdex, that has sort of almost pushed that first choice to the second.
What I'm hearing there is you're pretty much switching to pomalidomide and adding either carfilzomib or daratumumab, depending on the scenario. What about you, Raphael?
It's a very, very similar practice. Number one is almost always I replace lenalidomide with pomalidomide. So I think what might change things is this upcoming trial, I believe it's the Candor trial, which is the daratumumab, carfilzomib, and dexamethasone. Because right now it's it KA or it's it DARA, and those are the two key players we have right now, plus dexamethasone, of course.
So it's,
But I think as they
same
converge,
for a year, it shouldn't be either or, it should be both.
I think that's where we're going to go. But right now, my practice, and I think the comorbidities and prior tolerance and exposure.
What if they've had daratumumab? We all said earlier we're going to start using daratumumab in the frontline setting, most likely. What do you do then?
So I think and this will apply for daratumumab, for IMiDs, and potentially for proteasome inhibitors. I think if someone relapses after a good period of control, one should assume that the drugs are still going to work again, which is very much the same paradigm that occurs, when people use combinations in non-Hodgkin's lymphoma with rituximab. And I think that the process of resistance is going to be different from what we see with the TKI, that is more binomial, sensitive or resistant. So I think most patients will still have that option, even if they relapse after an induction with, KRD-DARA.